There is a study I want to tell you about because I think it quietly answers a question a great many people are too embarrassed to ask. German researchers followed the same group of adults for over a decade. They asked them about their relationships at age 63, then again at 67, then again at 74. At the first 2 points, the answers looked roughly how you might expect. But at 74, something had shifted. When asked what mattered more, affection or sexual activity, this group gave affection the higher priority. Now, I want to be careful how I say this next part. That is not a consolation prize. That is not people settling for less because they could not have what they wanted. Their satisfaction levels had not collapsed. They had held steady across all three measurement points. What changed was not how happy they were. It was what they had come to value. And I think that finding deserves a whole video because almost nobody is telling you this. The internet will sell you 100 products promising to make you 25 again. Very few people will sit down and tell you what intimacy actually looks like at 78 and why it can be genuinely good. So that is what I want to do today. I am going to give you the real numbers on how many people your age are still sexually active because I suspect they are higher than you think. I am going to explain the single most common physical problem, which affects a majority of women, is entirely treatable, and which most women never mention to anyone. I am going to tell you about the medications that cause this, which people take for years without knowing. And there is one combination of a common heart medication and a common treatment that can kill. I will get to that, and if you or your partner take nitroglycerin, please make sure you hear it. Let me start with the numbers, because I think they will surprise you. In 2007, the New England Journal of Medicine published the first large national study of this in the United States. Researchers at the University of Chicago interviewed 3,005 people aged 57 to 85 in their own homes. Here is what they found. The majority of older adults were in spousal or other intimate relationships and regarded sexuality as an important part of life. Sexual activity did decline with age, but a substantial number of men and women remained sexually active into the 8th and 9th decades of life. That means into the 70s and 80s. And here is the finding I want you to hold on to. Sexual activity was tied more closely to overall health than to age itself. Health mattered more than the number of birthdays. A Swedish study of 1,680 adults over 60 found something similar. 46% of the whole group were sexually active. Among those aged 90 and above, about 10% still were. Activity and satisfaction were both positively associated with self-reported health and with living with a partner. So let me say the thing plainly. If you are 76 and still interested, you are not unusual. You are not inappropriate. You are ordinary, and the data says so. And if you are not interested, that is also entirely ordinary. And this video is not going to tell you that something is wrong with you. Now the problems, because they are common and most of them are fixable. In that American study, among people who were still sexually active, nearly half reported at least one sexual problem. For women, 43% reported low desire and 39% reported vaginal dryness. For men, 37% reported erectile difficulties. I want to spend real time on that second one for women because it is the most treatable thing in this entire video and the most consistently ignored. It has a name, genitourinary syndrome of menopause. Doctors abbreviate it as GSM, and the older term you may have heard is vaginal atrophy. Here's what it actually is. After menopause, estrogen levels fall, and the tissues of the vulva, vagina, and lower urinary tract change in response. They become thinner, drier, less elastic, and more fragile. The North American Menopause Society position statement puts the prevalence at somewhere between 27 and 84% of postmenopausal women. Other reviews estimate 50 to 70%. Now here are the three things about it that I most want you to know. First, the symptoms are not only sexual. Yes, it causes dryness and pain with intimacy, but it also causes urinary urgency, frequency, burning when passing urine, and recurrent urinary tract infections. A great many women being treated for repeated urine infections have this underlying cause and have never been told. Second, and this is critical, it is progressive and it does not resolve on its own. Unlike hot flushes, which typically fade with time, this gets worse without treatment. Waiting does not help. Third, and this is the good news, in most cases, it can be effectively managed. The options range from simple to prescription. Vaginal moisturizers used regularly rather than only during intimacy, and lubricants used at the time. Those are over the counter and help many women with mild symptoms. For moderate to severe symptoms, there are low-dose vaginal estrogens, vaginal DHEA, and an oral medication called ospemifene. Now, the question I am always asked at this point, so let me address it directly. Many women hear the word estrogen and think of the hormone therapy headlines from 20 years ago and stop the conversation there. Low-dose vaginal estrogen is a different situation from systemic hormone therapy. It is applied locally in very small amounts, and the position statement notes that when low-dose vaginal estrogen is used, a progestogen is not indicated. I am not going to tell you it is right for you because I do not know your history, and there are genuine nuances, particularly for women with a history of breast cancer, where this is a shared decision with your oncologist. What I am telling you is that it is a legitimate medical conversation and that the reviews consistently describe this condition as underdiagnosed and undertreated, not because treatment does not exist, because nobody brings it up. So here is the sentence I want to give you. Say to your doctor, I think I may have genitourinary syndrome of menopause, and I would like to discuss treatment options. Ask by name. That sentence skips the entire embarrassing preamble, and any doctor will know exactly what you mean. Now, the medications, and this affects both men and women. A very large number of common prescriptions affect sexual function, and people take them for years assuming the problem is their age. The usual suspects include certain blood pressure medications, particularly older beta blockers and thiazide diuretics, many antidepressants, especially the SSRI class, some medications for prostate enlargement, antihistamines, which contribute to dryness, and several others. Here is why this matters so much. There are frequently alternatives within the same class that have a lower burden of these effects. A change of medication, not a new one added on top, sometimes solves the whole thing. But your doctor cannot offer that if they do not know it is a problem. And surveys consistently show that neither doctors nor patients raise the subject. So if something changed and you can roughly date it to when a medication started, that is worth saying out loud. Now, the warning I promised, please listen carefully to this one. If you take nitrates for heart disease, that includes nitroglycerin tablets or spray, isosorbide, and related medicines, you must not take erectile dysfunction medications such as sildenafil or tadalafil. The combination can cause a catastrophic drop in blood pressure. People have died from this, and here is the practical danger that concerns me most. Some men obtain these medications outside of a proper consultation from the internet or from a friend, and their cardiologist never knows. Others buy unregulated herbal or natural products marketed for this purpose. Testing has repeatedly found that many of those products contain undeclared prescription drug ingredients in unpredictable amounts, which is exactly the same danger with none of the labeling. If you take nitrates, this is a conversation with your doctor, and there are other approaches available to you. Please do not work around it. Now, let me come back to where I started because I do not want the medical section to be the whole of this video. That German study found that at 74, affection was given a higher priority than sexual activity. I want to unpack why that might be because I do not think it is simply decline. Physical touch does real things. It is not a lesser substitute for something else. Holding hands, sitting close, an arm around a shoulder, sleeping in contact with another person. These are not nothing, and treating them as a runner-up prize is, I think, a mistake that costs older couples a great deal. There is also something the research on older couples repeatedly finds, which is that intimacy often becomes less performance-oriented and less goal-directed with age. When intercourse is no longer the assumed destination, a lot of pressure comes off. Some couples describe that as a loss. Others describe it as a relief. and as the point at which things became more relaxed and more affectionate than they had been in decades. Both of those are true experiences, and I would not argue with either. But I would say this to the men watching, because I think you need to hear it most. The channels that tell you your worth depends on an erection at 80 are selling you something. They are not helping you. Interestingly, that Swedish study found that men in every single age group reported sexual dissatisfaction more commonly than women did. More men were unhappy about this than women were. I suspect a good deal of that gap is not physical at all. It is expectation, and it is shame, and it is the sense of having failed at something. If that is you, I would gently suggest that the problem may partly be the standard you are holding yourself to. Now, a few practical things worth saying plainly. Talk to your partner. I know how obvious that sounds, and I know how rarely it happens. Couples in their 70s frequently spend years each assuming the other has lost interest when neither has, because neither wanted to raise it. That is a genuinely common and genuinely fixable situation. Second, if one of you has had a heart attack, a stroke, a hip replacement, or a cancer treatment, ask your doctor specifically about resuming intimacy. There is real guidance for this, and most people never ask, so they simply stop permanently out of a fear that was never confirmed. Third, and I will say this without moralizing, sexually transmitted infection rates have been rising in older adults, and testing rates in this age group are low, partly because clinicians do not think to ask. If you have a new partner later in life, that is a reasonable thing to raise, and there is nothing undignified about it. Now, the things that need a doctor rather than reassurance. Any bleeding after menopause is never normal and always needs investigation, however small. Pain during intimacy that is new or severe or does not respond to lubricants. A new lump or skin change on the genitals. Erectile difficulty that comes on suddenly or is accompanied by chest symptoms or breathlessness on exertion, because the penile arteries are narrower than the coronary arteries and often show trouble first. I have made a separate video on that link, and I would encourage you to watch it. And a sudden loss of desire alongside fatigue, low mood, or weight change, which can indicate thyroid problems, depression, or other treatable conditions. 3 honest statements before I close. The research here describes populations, and your own situation may look nothing like the averages, which is fine. Cultural and generational attitudes shape how people answer these surveys, and there is almost certainly some underreporting in every study I have quoted. And this video is education, not medical advice. I am a physician, but I am not your physician. Let me finish with the thing I actually wanted to say. I have had a great many patients over the years apologize to me for raising this subject. They lower their voice. They say they know it is silly at their age. It is not silly, and I want to be very clear about that. Wanting to be touched is not a young person's need that you are supposed to grow out of. It is a human need, and it does not have an expiry date. That German study found that by 74, people had rearranged what they valued most and put affection at the top. I do not read that as a story about decline. I read it as a group of people who had worked out what actually mattered and stopped chasing what did not. If something is genuinely wrong, there is very likely a treatment, and I have given you the names to ask for. And if nothing is wrong, and things have simply changed shape, that may not be a problem to be solved at all. Tell me in the comments whether anyone has ever raised this subject with you at a medical appointment. I am fairly confident I know the answer, and I think that is worth talking about. Take care of yourselves, and I will see you in the next one.